Okay. Okay, hi. Okay, this is our talk on the Micropulse transcleral laser. Let's get rid of this in this let's close this so that we can see the title. Okay, that's great. Okay, today we're talking about Micropulse transcleral laser therapy, and very fortunate to have with me Dr. Maria Aquino, who is also one of the pioneers with me on this laser. The two of us prototyped this device some years ago, and we'd like to share our experience with you on how to get a good transcleral laser therapy done and how you can use it to your benefit and how effective you can expect it to be. So let's start this. I have to do some disclosures since we are inventors of this device. And now, micropulse transcleral laser therapy is not cyclophotocoagulation. It's a transcleral laser to the pars plana. It is not over the pars plicata. So please remember, we are not talking here about cyclophotocoagulation per se. We are talking about transcleral laser, which causes increased uveoscleral outflow by having a micropulse that's only causing a little bit of heat rise to increase the outflow and lower the pressure. This outflow is hypothesized to be by making the RPE at the pars plana more leaky and allowing an increased uveoscleral outflow through various cellular reactions. That's why we don't need a huge amount of heat. We just need cellular activity to change by the laser effect and make the uveoscleral area more leaky. Now, you tend to use this really on most patients these days. Initially, years ago when we first started, we wanted to use this on severe disease, but as time went by, we began to realize because of the safety profile and the moderately good effectiveness, we started using it on a wider spectrum. So we do use it on primary open-angle glaucoma. We do use it either before or after glaucoma drainage surgery to help augment pressure. We do use it with drugs. And it does have a good safety profile, but you've got to do the laser correctly. And when we say that correct laser, it means your technique must be good, your settings must be right, and you must also remember to stay on target. It's useful in uncontrolled IOP, reduction in the medication burden. Let's say you have one drop, rather than increasing to two, you could probably do a bit of laser instead of increasing. If the patient is not yet fit for surgery and you need to just lower the pressure temporarily, or perhaps if your pressure is very, very high and you don't want to lower the pressure excessively fast, you could do a micropulse first, bring it down from the 40s to the 20s, and a couple of weeks later, then do your definitive incisional surgery. And of course, after incisional surgery, if your pressure is less marginally higher than you want it to be, it can help to augment your incisional surgery to lower the pressure. Here's what the probe used to look like. And now the original micropulse probe is this one over here. And you can see that this is you have to see where the fiber optic comes out. That part has to go over the pars plana. It's a bit thick on the sides. So with a new Gen 2 probe, it's a bit slimmer. It's easier to get in, but Gen 2 probe is not available in every part of the world yet. So some markets will still have this original probe. And here's Cecile to tell you a little bit about surgical technique.
You can see from this video the technique of performing micropulse transcleral laser therapy. You have the probe and see to it that you have the probe focus on the pars plana, not the pars plicata, and do not move your probe too anterior or you may end up having dilated pupils. And as you move the probe through to and fro, do it in a slow sweep of approximately about 10 seconds, 10 to 20 seconds per sweep, or it depends on the number of treatment that you're going to perform inferiorly. This is the second video shows you the generation 2 probe. And as you can see here, the probe is moved slowly, avoiding the 3 and 9 o'clock. And with this type of eyes, it's very easy to see that you can move the probe swiftly. But if you have patients who have very limited palpebral aperture, then there's a difficulty moving the probe. But with this new generation 2, you can still use and perform the procedure without difficulty.
And when you do this laser, remember that you have to keep on the target. So if the eye is inflamed, you must make sure that you do have the conjunctiva adequately compressed, not too hard that you cause tears, but enough to blanch the blood vessels so that the energy doesn't get taken up by the red cells on the conjunctiva. And of course, don't go forwards, because if you go out of target and start treating the pars plicata, you may cause mydriasis. Use a good coupling agent so that the surface of the eye doesn't get traumatized unnecessarily. And if you see areas where there's pigmentation or subconch hemorrhage, maybe you shouldn't treat those areas because the energy will be taken up on the surface and that will cause some burns. So avoid areas with thin sclera, pre-existing blebs, or failed trabs. And of course, try not to go over a placed tube because you may traumatize the conjunctiva due to the change in contour of that side. Bear in mind, this is a very useful temporizing procedure just to lower very high IOP before definitive therapy. Now, how well does it work when you combine it with cataract surgery? We find that in our hands, we have been using this laser on the table just prior to incisional cataract surgery. We do the laser prior to doing the cataract, and we found that the results have been good. Pressure lowering has been consistent and has been reproducible. And medication the reduction is also very encouraging here when you do phaco with a micropulse transscleral laser on the table at the same sitting. Do the laser just before you start your cataract. How does it compare with other ways of doing a cataract with other forms of pressure lowering? So let's have a look at what happens when you have a small case series of phaco micropulse versus phaco iStent. And here we have a group of patients, about 15 in the iStent group and 17 in the Micropulse group. Otherwise, not much difference between them. You can see here that pressure lowering in the phaco iStent group was not much, at 1 year pre-op was 1 year. The MP3 group did a little better, but it wasn't statistically significant. You can see there is pressure lowering in both groups at 1 year. The important thing is that medication was reduced in the iStent group from 1.3 down to 0 at 1 year, and in the MP3 group from 1.6 down to 0.2. Both were statistically significant, and between the two groups, there was no difference. So both lowered medication about equally well. How about Hydrus? If we do a phaco micropulse with a phaco Hydrus, how's the pressure change? And here's some data from 12 months. You can see that from baseline of 17 to a pressure at 1 year of 15 for the phaco Hydrus group. And the phaco Hydrus group did have pressure lowering, but it wasn't statistically significant. For the phaco MP3 group, it went from 16 to 14, and at 12 months, this was just significant. Between the two groups, there was no significance. So there was pressure lowering, but not very different between both groups. Both groups lowered pressure about the same. Similarly, for medicines, in the Hydrus group, it went from 1.4 to 0.2, and in the MP3 group, it went from 1.5 to 0.2, and both were statistically significant at 12 months, with no real difference between the groups. So in other words, both lowered it about equally well. Therefore, we can say in summary that this is a versatile, non-incisional IOP lowering procedure. There's a wide range of indications from severe to mild, and it can be used in combination with cataract surgery very safely and effectively, and have good success rates when compared to mixed procedures combined with cataract surgery like iStent and Hydrus. I thank my colleagues, without which none of this work could be done. And at this point now, we will end the presentation. Do we stop share? Okay, stop recording.